Hello, and welcome to the Duke Cardiology Conference. I'm Sunil V, Assistant Professor of Medicine here at Duke University Medical Center. Today's program is entitled Updates in Atrial Fibrillation Care, and our distinguished guest is my colleague, Patrick Hranitzky, Assistant Professor of Medicine here at Duke and part of the Electrophysiology Service. Pat, thanks for joining us.
Thanks, Sunil. It's good to be here.
So, when we take care of patients in the hospital with heart failure, one of the most common things we come across is atrial fibrillation. So, for example, last week when we were rounding on the inpatient service, we encountered a 74-year-old female who had a history of congestive heart failure, ischemic cardiomyopathy, was admitted to the hospital with a heart failure exacerbation. And part of her clinical presentation was that she was in atrial fibrillation with a very, very rapid ventricular rate. And on rounds, part of the discussion revolved around what are the advantages of rate control versus rhythm control? What are the options for pharmacotherapy? What about anticoagulation? Is there anything new on the horizon with respect to curative therapies for atrial fibrillation? What can you tell us about that?
So actually, I think this is a great case because this brings to point a lot of different aspects of what we have to deal with atrial fibrillation. And this particular case example presents some of the challenges we deal with, particularly with rate control and even rhythm control. So hopefully we'll shed a little bit of light on that as we go through here. I think one of the first things we need to talk about is how big of a problem atrial fibrillation is, not only in the heart failure population but in the general population. And it is something that the incidence increases with increasing age. Obviously, this patient being 74 years old falls into a category of a group of people that atrial fibrillation is very common in, not to mention the heart failure population. But, as our population is aging, we're finding more octogenarians in the population. And as it turns out, close to 1 in 10 of the population of octogenarians has atrial fibrillation. And in reality, in the U.S., there's an incidence of greater than 400,000 cases per year of atrial fibrillation. Well, aside from the incidence, the prevalence of atrial fibrillation, again, as I mentioned, is very high in the elderly population. And as that population grows, obviously, we're going to see more patients with atrial fibrillation, and we're going to be having to deal with these people as well. Well, specifically, in our patient, you mentioned that our patient has heart failure, and this is something that in and of itself, independent of atrial fibrillation, can be a difficult thing to deal with. And we know that atrial fibrillation is more common in the heart failure population, and depending on what study you look at, it ranges anywhere from about 10% to 50%. So most of those trials center right around 20 to 25% of patients with heart failure population having concomitant atrial fibrillation. Well, one question I think we need to ask ourselves is why do we treat it? It's so common and it's the bane of a lot of physicians' existence because it's so difficult to deal with. Well, why do we treat it? What's the point? Well, for several reasons. We obviously want to prevent complications associated with atrial fibrillation, namely stroke and tachycardia-mediated cardiomyopathy. Patients that have poor rate control can end up getting cardiac dysfunction, and some patients who we don't necessarily know the primary cause of their heart failure may be mediated from atrial fibrillation and poor rate control. We also want to prevent CHF exacerbations that atrial fibrillation can predispose these patients to. In addition, we want to improve symptoms and quality of life. If we can control rate, many times we can improve quality of life and symptoms. As a matter of fact, for patients that we are trying to treat for atrial fibrillation, if we don't adequately control rate, then we can't say that we've failed at a rate control strategy. We have to show that we've achieved adequate rate control before saying this patient needs rhythm control. And then, of course, one of the other things we want to do is try to restore and maintain sinus rhythm in these patients if they continue to have symptoms despite rate control. Well, one of the biggest burdens that we deal with atrial fibrillation is the stroke risk, and there are multiple factors that predispose people with atrial fibrillation to stroke. And the most common are outlined here. We typically define them as the CHADS-2 risk score. The CHADS standing for congestive heart failure, high blood pressure or hypertension, age greater than 75. Diabetes mellitus, and stroke, which carries a factor of 2. And these are the most provocative or the highest risk factors associated with stroke in the AFib population. And again, our patient that we're talking about, again, is we mentioned has heart failure and is also female, which is a secondary risk factor for stroke. So this is somebody that we definitely need to pay attention to anticoagulation with. These factors are divided into more weaker risk factors and higher risk factors. Clearly, a patient that has had a prior TIA or stroke is going to be someone who's at very high risk for having a recurrent event related to their atrial fibrillation. Heart failure, advanced age, high blood pressure, and diabetes are more moderate risk factors. And there's some debate about heart failure in that group, and maybe we're starting to see that it may be more of a risk factor than we really thought, but that's still a subject of debate. And then some of the weaker risk factors include female gender, age between 65 and 75, concomitant coronary artery disease, and then thyroid disease as well.
Pat, for our viewers, talk a little bit about heart failure versus LV dysfunction, because I think there's a perception out there that what we're talking about is just LV dysfunction. What about patients who have normal ejection fractions that are measured but come in with clear heart failure who may have atrial fibrillation? Yeah,
that's a very good point, because the patient with systolic dysfunction and a poor cardiac output is a different patient than someone who has normal LV function who presents with atrial fibrillation. For example, the classic example is the octogenarian with a normal LV systolic function and long-standing high blood pressure who has significant diastolic dysfunction. It's that, the analogy I like to use is a normal heart is one that is like the balloon you've blown up 50 times. If you try to blow it up the 51st time, it's pretty easy to get open. Well, that octogenarian with high blood pressure has that balloon that's never been blown up before. It's hard to get that thing to fill, and it doesn't want to fill. And as a result, it can end up causing pulmonary edema and heart failure exacerbation. So these are two distinct groups, but atrial fibrillation can be a major contributor in both instances. So let's talk first about rate control, because as I'll show as we move through this, there's lots of data to support rate control in this population. But especially in the heart failure group, we run into some challenges with rate control. For example, a lot of the medications that we use can cause hypotension in patients that may already be somewhat hypotensive. So we're limited in that regard in many instances. We can often use digoxin in these patients that won't have that effect. But we know that from the DIGE trial that digoxin isn't necessarily something that's going to benefit these patients with heart failure. And as it turns out, a lot of these patients with heart failure are going to have defibrillators. And digoxin is shown to be associated with an increase in ICD firing. So we certainly don't want to do anything detrimental to these patients, but we do want to achieve adequate rate control. Another downside of some of the rate control medications is they can be negative inotropes, particularly the calcium channel blockers, which we don't like to use in patients with systolic dysfunction for that reason, because it is a negative inotrope. We do know that beta blockers have a benefit in this population, but beta blockers are often not enough to get adequate rate control. The medications themselves can cause bradycardia in the Tachy-Brady syndrome, and in a lot of these patients who have this, we are a little bit hesitant to put them on a lot of nodal blockers to control their tachycardia if they do have periods of bradycardia as well, and in some instances we have to put a pacemaker in for that reason as well. And then fatigue is another side effect of a lot of these medications, and intolerance to the medications due to fatigue limit the use of these medications in a lot of these people. The medications cannot have good efficacy. We maybe have them on max dose of these medications and still not have adequate rate control. And before we move on, I think it's important to know what adequate rate control is. I mean, is adequate rate control anything less than 100? Is it an average heart rate of 60? Well, if you look at in most of the studies, what's considered adequate rate control is a heart rate of daily living at 80 beats a minute, and then going up to about 110 beats a minute on a 6-minute hall walk. So that's the kind of range we're talking about for adequate rate control.
And you said something very important there, because I think one of the issues with rate control is that oftentimes patients are laying in bed in the hospital where they may achieve adequate rate control. And it sounds like the key is to make sure that they can get up and walk around without a heart rate shooting up into the 160.
Absolutely, and that's particularly important when we're using digoxin for rate control, because digoxin, as it turns out, does a pretty good job at rate control when patients are sedentary. But as soon as the patient gets up and walks around, then the effect of digoxin is pretty much gone. Mm-hmm. So you're exactly right. We do need to assess patients when they're up and ambulating to see if they are truly achieving adequate rate control. And then, of course, one of the definitive or final things that we can do to achieve rate control is to do catheter procedures to ablate the AV node and then do permanent pacing, either RV-only pacing or cardiac resynchronization therapy, which we'll talk about in just a minute as far as the data goes with that. Well, I mentioned before that rate control is important, and this is a case study by Grogan that demonstrated an example of a tachycardia-induced cardiomyopathy in a patient with atrial fibrillation, not too terribly different from the patient we described, female, a little bit younger, but a severely depressed ejection fraction while in atrial fibrillation, going 150 beats a minute, achieved adequate rate control and had a significant improvement in the ejection fraction to normal range, but then had medical noncompliance, and again, the ejection fraction dropped, and then it achieved a rhythm control strategy with amiodarone, and again, improvement in the ejection fraction. So this is something that I think is oftentimes missed, is the tachycardia component to a patient's diminished heart function. Well, we spent a lot of time talking about rate control, but we haven't really talked about rhythm control, and I think it is something that's very important. There have been multiple clinical trials that have demonstrated that in patients, especially with asymptomatic atrial fibrillation, that rate control is superior to rhythm control. But the caveat to that is that all of these studies have been conducted with antiarrhythmics as the rhythm control strategy. This includes the pharmacologic intervention in atrial fibrillation trial, the strategic trial of treatment of atrial fibrillation, the AFFIRM trial, which is the one we reference most often. But I think it's important to note, again, that all of these trials, the rhythm control arm was antiarrhythmic drugs were used. And we'll talk a little bit about some of the potential harm that antiarrhythmics can do, especially in the heart failure population. Well, we mentioned definitive therapy for rate control being the AV node ablation pacemaker, and we also know that in the heart failure population that cardiac resynchronization therapy in patients with cardiac dyssynchrony is shown to be beneficial. So one study that was conducted in the early 2000s was the PAVE Trial, which enrolled 184 patients scheduled for AV node ablation for refractory AFib and poor rate control. These are patients who had failed nodal blockers for one reason or another. They were their ejection fractions ranged anywhere from normal to severely depressed. And the primary endpoint was we were comparing AV node ablation with RV pacing to AV node ablation with CRT. The primary endpoint was a composite endpoint of quality of life, 6-minute hall walk, and improvement in ejection fraction. And as it turns out, there was the patients who actually did get CRT therapy maintained their ejection fraction after the procedure, whereas those that received RV-only pacing had a significant decrease in their LV function. Now, we know that RV pacing in many instances can cause hemodynamic compromise in a lot of patients. And what was determined from the PAVE trial is that the patients that had underlying LV dysfunction, the patients with underlying LV dysfunction were the patients that benefited most from CRT. We also saw an improvement in 6-minute hall walk in CRT as compared to RV-only pacing. Another study looking at specifically at the heart failure population and rate versus rhythm control was the AF-CHF trial. And again, in the AFFIRM, the STAF, the SPAF, the pharmacologic intervention and AFib trials, these patients, for the most part, had normal function. In the AF-CHF trial, these patients had ejection fractions of 40% or less. So this is the type of patient that we're talking about here. And these patients were randomized to rhythm control, and about 70% of them got amiodarone, or rate control. And the primary endpoint was cardiovascular death. And as it turns out, and you can see from this graph, that there was really no difference in the primary endpoint in rate versus rhythm control. And in the patients that did get rhythm control, a fair number of them, more so than even rate control, had problems with bradyarrhythmias, a little bit contrary to what you might think. The results were similar to AFFIRM, but again, the thing to remember about this trial is the rhythm control arm was with antiarrhythmic drug, but this is the population we're talking about. This is specifically the CHF population. And again, here's the Kaplan-Meier curve for cardiovascular mortality. And again, these two lines line right up with each other. No significant difference in the primary endpoint. And if you look at secondary endpoints across the board, including stroke, et cetera, these secondary endpoints, again, no difference between rate and rhythm. Well, why bother why even strive for rhythm control? Well, there are multiple reasons. It's well known that atrial fibrillation can cause hemodynamic abnormalities, especially in the heart failure population, related to stroke volume. It can cause increased LA pressures, shortened diastolic filling times, AV valvular regurgitation, and irregular and rapid ventricular rates. The other thing is the persistence of AFib can lead to electrical remodeling in the heart that further begets atrial fibrillation. And then most importantly, patients are symptomatic. Many of the patients are symptomatic, particularly with fatigue. Fatigue is the most common side effect of atrial fibrillation, or symptom associated with atrial fibrillation. But having said that, it's difficult to tease out in the heart failure population whether it's the AFib or the heart failure.
Yeah.
Well, let's go back, and we talked a lot about the AFFIRM trial and comparing rate and rhythm control, but there were a few things that came out of the AFFIRM trial that we really need to look at. And there was sub-studies done to determine what factors within these patients contributed to the ones that did well and the ones that did poorly. And as it turns out, sinus rhythm was associated with a marked improvement in mortality. Not only in the rhythm control, but also in the rate control strategy. Not all the patients that were randomized to rate control were in atrial fibrillation persistently. And the other thing was that rhythm controlled drug use was associated with an increased mortality. And these, as it turns out, these really offset each other, which makes you wonder whether keeping somebody in sinus rhythm may actually have a mortality benefit for them. We don't know the answer, but we'll talk about that in a minute. I mentioned before that having atrial fibrillation and staying in atrial fibrillation can lead to more atrial fibrillation. This was originally demonstrated by Wiffels in an animal model where the animal was put into atrial fibrillation and sustained in it for extended periods of time. And the longer that the animal was kept in atrial fibrillation, the longer it persisted, to the point where the AFib persisted. And this is also true as we've seen in the humans. Now, if we're going to choose a rhythm control strategy for the patient who is symptomatic, we have several treatment options depending on the underlying substrate. But as you can see from this trial, we have a few limitations in the heart failure population. We really only have 2 medications that we can use in this population that are safe. We know from the CAST and the CAST-2 trial that Class 1 agents in patients with structural heart disease can have detrimental effects. We also know from the ATHENA trial that patients with heart failure it's not recommended to be treated with dronedarone. So the 2 medications we do have that have been shown to be safe are amiodarone and difetilide, and I'll show some data on those in a minute. And then, despite the fact that those are considered first line, the best efficacy that we can achieve is about 60%. So for those who fail, the next line of therapy is going to be catheter ablation. Well, the thing we know from the stroke prevention and AFib trial is that in structural heart disease, antiarrhythmic drugs are bad for treating atrial fibrillation. Patients do poorly. The relative risk associated with Antiarrhythmic drug use in structural heart disease in the SPAF trial was 4.7. Not trivial, not trivial. Well, this is data from the DIAMOND-HF trial, which looked to see if dofetilide was safe in patients with heart failure and concomitant atrial fibrillation. And as it turns out, dofetilide was safe. It did have a much higher incidence of spontaneous conversion from atrial fibrillation to sinus rhythm, maintenance of sinus rhythm, and decrease in heart failure hospitalizations as compared to placebo. And there was no difference in mortality. So we do have an antiarrhythmic that has been proven safe in atrial fibrillation. Another study that was done in the heart failure population was the CHF STAT trial. And there was 667 patients enrolled. Of that, 15%, or 103 patients, had concomitant atrial fibrillation. Half the patients received amiodarone, half received placebo. No difference in mortality. However, in that study, it was in the pre-beta blocker era for heart failure. So you have to take that into account as well. So if the patients that didn't receive amiodarone would have all been on beta blocker, maybe we would have seen a mortality difference there. I mentioned before that antiarrhythmic drugs actually have pretty poor efficacy, especially in the heart failure group. And the best efficacy we've seen was from the AFFIRM trial, where we had newer antiarrhythmics as compared to STAF as compared to the STAF trial. But still, achieving 40% of sinus rhythm at follow-up is pretty poor. Well, there's some other medications that have been shown to have upstream benefit for patients with atrial fibrillation, and as it turns out, a lot of these medications are also good for patients with heart failure. So these are the kind of medications that our patient that we're talking about should be treated with anyway. Well, we're going to talk a little bit about catheter-based therapies, but before we do, let's talk a little bit about the mechanisms very briefly. There are multiple mechanisms associated with atrial fibrillation, and depending on whether it's paroxysmal or persistent will depend on what degree these various factors play a role in. One thing we know is that the pulmonary veins seem to be the common trigger sites for atrial fibrillation. About 80% of patients with paroxysmal atrial fibrillation have their triggers in the pulmonary veins. There are rotors or drivers that sustain this fibrillatory function at the junction of the pulmonary veins in the left atrium. What we also know is that there's really a critical mass of left atrial tissue that's needed to sustain this function. This is why we see patients with larger left atria more frequently have more persistent atrial fibrillation. Also, the autonomic nervous system plays a key role in the initiation and maintenance of atrial fibrillation, both the parasympathetic and sympathetic nervous systems. The parasympathetic nervous system is responsible for shortening refractoriness or decreasing the interval at which the heart tissue can conduct, and then sympathetic stimulation results in ectopic activity, so initiating the initiators of atrial fibrillation.
Are the effects of the ACE inhibitors potentially related to reductions in volumes or potentially remodeling of the heart that may affect that?
Absolutely, that's a great question, and I think that's the main function of that has to do with remodeling, just like it would in the ischemic population, but also mainly in the remodeling and the deposition of collagen and fibrosis in these patients with high blood pressure and even valvular disease. So we know about these various triggers and the mechanisms of atrial fibrillation, and so a number of years ago there were surgical procedures done to remedy this, and essentially the idea was take out the triggers, debulk the atrium, and alter atrial transport, and theoretically you can keep a patient in sinus rhythm, and this was the original Cox Maze procedure. The pulmonary veins were isolated by slicing up the atrium. The appendages, right and left atrial appendage, were removed. And then linear ablation was done between the mitral valve and the tricuspid valve to eliminate flutters. And this worked greater than 90% of the time at preventing atrial fibrillation. And the reasons were several and addressed the issues of the mechanism we mentioned. Isolating the pulmonary veins, debulking the atrium, and allowing more organized atrial transport through the atria. So a group in Bordeaux, Michel Hasseguer and his group, determined that the main triggers associated with atrial fibrillation come out of the pulmonary veins. And his group figured that if we could ablate these triggers in the pulmonary veins, that we could eliminate atrial fibrillation in the population, specifically with paroxysmal atrial fibrillation. And this has evolved to the point where we've been doing catheter ablation as mainstream therapy for drug-refractory symptomatic atrial fibrillation. Well, how does this procedure work? Well, in the paroxysmal patient, for the most part, it's eliminating the triggers. But in the heart failure population, it's more complicated than that. Because by the time a patient's developed heart failure and the chamber's dilated, you have to do more than just treat the triggers. You have to do other things to address the substrate. Take out the rotors, take out the drivers, do some atrial debulking. And this is the reason that these procedures work in this population. Take out some of those autonomic inputs that contribute to the atrial fibrillation. This is typically done with a catheter called a Lasso catheter, which has multiple poles around it, where we can determine where the electrical activity is in the pulmonary veins. And then we can put burns there to isolate those veins from the rest of the atrium. This is an example, if I can run this movie here. Not sure. Whoop. There we go. Of an example of a patient who's undergoing a procedure, and I just want to kind of walk through this so I can tell you a little bit about what's going on. In the heart failure population specifically, it's very important to debulk the atrium, find the areas of rotors and drivers outside the pulmonary veins. And to do that, we have to have a map created so we know where we've been and where we need to go. Well, there are multiple systems we can use to do that, and we can guide where we're going to go based on a previous MRI image so we know where the pulmonary veins are and the other structures in the heart. And we can use intracardiac ultrasound up in the left corner there to see in real time where our catheter is and where we're delivering lesions. Because if we do have to do what we call linear ablation and debulk the atrium with lines in the heart, similar to a Maze procedure, we want to make sure we don't have gaps in the lines. And using these kind of modalities can help us in keeping those lines contiguous. So does it work, I guess? One question we have to ask ourselves is, if we're going to go through this catheter procedure, is it going to be effective? And is it going to be more effective than antiarrhythmic drugs? And there's multiple studies to show the efficacy of atrial fibrillation. Most of these studies have been done in patients with paroxysmal AFib and patients that have no structural heart disease. In this slide here, you can see that in the second trial by Michel Hasegaer, close to 50% of the patients had concomitant structural heart disease, and the patients were AFib-free off drugs at usually 12 months follow-up, and in this particular study, close to 80% of the time. Well, the other question we have to ask is this safe to do? I mean, if it's effective, it's one thing, but if it's not safe, it's another. So this is data from the worldwide survey by Ricardo Capato, who surveyed 85 centers across the globe, greater than 25,000 procedures, to determine what the estimated complication rate was. And the overall complication rate was 4%. And this included patients with concomitant heart failure, coronary disease, and other comorbidities. Well, there have been some studies to look at catheter ablation in the heart failure population. The PABA CHF trial, which was designed by Andre and Natali, looked at patients with symptomatic drug-refractory atrial fibrillation and depressed ejection fractions with concomitant heart failure, class 2 to 3 heart-associated heart failure. The patients were randomized 1-to-1 to pulmonary vein antral ablation or catheter ablation for atrial fibrillation and AV node ablation with cardiac resynchronization therapy. So again, we know that CRT can help patients with diminished ejection fraction. So the study was designed to give the benefit of the doubt, I guess I'll say, to the AV node ablation group.
So no antiarrhythmic drugs driving the mortality in one arm like in the previous
That's correct. Study. That is correct. And it was a composite endpoint of change in ejection fraction, 6-minute hall walk, and quality of life based on a heart failure questionnaire. Now, the first thing that we need to make sure of is that the patients who actually got randomized to catheter ablation actually had successful ablation. And as it turns out, roughly 70 to 75% at the 6-month follow-up maintain sinus rhythm without antiarrhythmic drug. Okay, because obviously if these patients were being treated with antiarrhythmic drug, it would cloud our true results of the catheter ablation. So at 6 months follow-up, 75% no antiarrhythmic drug, free of atrial fibrillation. And here are the results. There was a marked improvement in ejection fraction with the patients who underwent pulmonary vein antral ablation. And the patients that underwent AV node ablation and CRT had very similar results to that of the PAVE trial. You see, they maintained their ejection fraction, did not drop their ejection fraction, but did not have improvement. Also, there was improvement in 6-minute hall walk and heart failure questionnaire in the patient group that received catheter ablation. Well, Michel Hasseguer specifically looked at catheter ablation in the heart failure group as well, and he designed a study it was a prospective study, non-randomized, where patients with heart failure and symptomatic atrial fibrillation were treated with catheter ablation of atrial fibrillation, and then compared with patients who were getting catheter ablation for atrial fibrillation that didn't have heart failure. And he wanted to see if there were improvements in ejection fraction, quality of life, etc. And as it turns out, there were significant improvements in ejection fraction, in quality of life, in functional capacity. But in addition, they looked at patients who had had adequate rate control prior to the procedure, as well as those who did not. And even patients that had adequate rate control had an improvement, a significant improvement in ejection fraction, an average of 21% when they got catheter ablation. So this shows that there's benefit even on top of rate control for catheter ablation. So the one thing that hasn't been looked at in the AFib population is whether there's a mortality benefit to catheter ablation for these people. And that is something that's going to be addressed and is being addressed in the CABANA trial, which is planning to enroll over 3,000 patients in over 200 centers worldwide. And these patients include patients without structural heart disease, but also patients with structural heart disease, and specifically patients that are a little bit higher risk, maybe advanced age or may have stroke risk factors, to determine if there's truly a survival benefit to getting catheter ablation. The primary endpoint will be all-cause mortality, but of course secondary endpoints that will be looked at are stroke, the burden of atrial fibrillation after the procedure, quality of life, cost of effectiveness of the procedure, and then cardiovascular death, and then they'll also look at composite endpoints as well. So this is where we're left with this population. We have a lot of provocative data to support catheter ablation as a rhythm control strategy for patients with symptomatic atrial fibrillation, even on top of adequate rate control. So I think that once we have our data from CABANA out, we might be changing our practice patterns a little bit in this population.
That was a terrific talk, Pat. And one thing that you said repeatedly, which really caught my attention, is that you kept saying our patient, and that really brings to mind a question that I had for you: is collaboration between electrophysiologists and general cardiologists in primary care. What are things that you recommend for non-electrophysiologists to do for atrial fibrillation before bringing in the electrophysiology specialist? Because right now, the burden of AFib in the patient population, there just aren't enough electrophysiologists to go around. And I think you pointed this out in your talk, is that what defines failure of rate control?
Yeah.
So talk a little bit about the approach that maybe primary care cardiologists should take when encountering a patient like the one we described.
Yeah. So as I mentioned before, a lot of times the heart failure patient is very difficult to deal with, just based on the fact that there may be factors that limit the kinds of medications we can use for rate control. Obviously, calcium channel blockers we try to avoid in that population. As I mentioned before, beta blockers can cause hypotension. But I think for the primary care physician and the general cardiologist, the things to strive for first is doing the best job at achieving rate control while obviously maintaining a viable blood pressure and heart rate, because we really don't consider somebody to have failed rate control unless fail to rate control strategy unless they actually achieve a heart rate of daily living around 80 beats a minute, with a heart rate no greater than 110 with normal daily activities. And if a patient is asymptomatic and is rate control, once you achieve that, then there's really no data to support doing anything different. Okay. Well, the thing we do know about catheter ablation thus far is that the only improvements that we see are in quality of life. So if you achieve rate control and the patient is asymptomatic, then you're really not going to buy them much by achieving a rhythm control strategy. It's the patient that's still symptomatic that we're really targeting. So for the primary care physician and the general cardiologist, if you're unable to achieve rate control with standard measures, or if a patient remains symptomatic despite adequate rate control, and many times that requires a 24 or 48-hour Holter monitor in the presence of rate-controlling drugs to determine whether they have adequate rate control. If that is not the case, then that is the time to refer that patient to the electrophysiologist. And
then Cabana obviously will give us information on long-term survival.
Absolutely.
Terrific. Well, listen, that was a fantastic talk. My guest faculty today has been Patrick Hranitzky, one of my colleagues here at Duke. Pat, thanks again for joining us and providing us with this fantastic information.
Thanks, Sunil.
Until next time, then, for all of us here at Duke, this is Sunil Rao saying thanks for joining us and take care.